Karen Ng, and tonight we're going to do our online module for the opioid addiction and substitution therapy. I have no current or past relationships with commercial entities, and I have received a small speaking fee from the OPA for this learning activity. These are complimentary online modules that are made available through the funding from the Ministry of Health and Long-Term Care. Okay, so tonight we're going to talk about four main teaching learning objectives. We're going to apply the key recommendations from the 2017 Canadian Guidelines for Opioids for Chronic Non-Cancer Pain, or CNCP, especially as it relates to the efficacy and safety of opioids and the clinical implications of its opioid dose recommendations. I'll also talk about some common opioid tapering and or opioid switching methods for patients on high-dose opioids. We'll discuss some effective communication approaches to facilitate these opioid adjustments. And lastly, discuss communication approaches with our physician colleagues when we make these recommendations around opioid dose changes. And we'll try to use the pharmaceutical opinion program as a framework. So you can see in this slide, I think it comes to no surprise to all of us that we continue to face a public health crisis with regards to opioids. And these are some examples of headlines that I've captured over the last few months about the need for a change in the way we manage opioids, because people are continuing to have overdoses secondary to either laced fentanyl or a rise in high-dose opioids within the healthcare system.
So this slide depicts opioid prescribing trends in Canada, and this is more recent data capturing the trends of prescribing in several of the provinces within Canada. So we have some data for Ontario, Manitoba, Saskatchewan, and BC. And what you can see here is that over time, from 2013 to 2018, the proportion of patients who have been prescribed opioids haven't really changed much. And it's pretty consistent across all provinces that were captured in this study, so about 15%. So we have some stats on the right here. It says 1 in 8 people were prescribed opioids in those 4 provinces combined, an estimate of more than 4.6 million Canadians nationally. So these are very significant numbers with regard to the epidemiology of opioid prescribing. Furthermore, 1 in 5 people were prescribed opioids on a long-term basis, and this is described as opioid use, defined as someone prescribed opioids for about 90 days out of a 100-day period, so about 3 months. And then 1 in every 550 people on long-term opioid therapy die within roughly 2.5 years of their first opioid prescription. And this statistics continue to get more significant as the doses increases. So 1 in 32 people receiving more than 200 morphine equivalents in dose of opioids die of daily opioid-related causes. So certainly the prescription amounts haven't changed, and certainly there's a dose response with regards to mortality. So here we have a public health, Ontario Public Health did some population studies with regards to some of the mortality and morbidity of opioid use in Ontario specifically. And they captured data across from 2003 all the way to about the end of 2018. I don't believe we have data from 2019 yet. But you can see the different lines here. So I'm just going to draw your attention to the purple line, which is the ED visits, so emergency visits due to opioid-related issues. You can see there's a huge spike, and it continues to climb. So in 2016 to 2018, there's a huge jump that we had about 9,000 cases of patients presenting to Ontario hospitals related to opioid-related issues. And then furthermore, there's almost 1,500 patients that are admitted to the hospital because of opioid issues. And then the death rate is a significant outcome that we're worried about, that despite all the policies that we've made on the government level, in practice levels, the death of opioids or death related to opioid use continues to climb. So drawing from that data, they were able to look at some age-related issues, so cases of opioid-related emergency visits in 2018. And this just draws your attention to the age group that is most affected with opioid issues. So it's really the ages of 25 to 44 is the biggest group of patients that have these opioid-related issues. And that's concerning from a public health perspective, because these are the patients that are working or in school or really contributing to the society, and these are the groups that are being affected. What's also surprising is you can see the 45 to 65-year-old group as well. So again, a working population are also affected by these opioid issues and are suffering some of the sequelae due to opioid use.
So again, this begs the question, I alluded to the issue of high dose, whether or not there's a link between opioid mortality and dose. So this question I pose to you guys is, patients on stable high-dose opiates, is it safe to continue on such doses? And you can see from the slide, this in fact is a myth. And we know that there are a lot of thresholds that have been published with regards to what is considered high dose. And though there's not strong evidence to support one absolute appropriate dose threshold, we know that the higher the dose, the higher the risk of overdose death. This has been clearly shown in a landmark study done by Tara Gomes and colleagues in 2011 when she looked at some ODB data and tried to link the risk of opioid mortality and morbidity with the dose of opioids. You can see in the red box here that anyone taking a dose above even 50 to 99 morphine equivalency, there's a signal towards an increased risk of mortality. So the odds ratio is almost 2 when you even have patients on 50 to 99. And certainly that risk continues to rise as the dose gets higher beyond that 200 morphine equivalency. So this study helped to validate some of the safety around the watchful dose and the significant association between high-dose opioids and mortality. And what is also interesting to note is that we used to think that 200 was the cutoff or the watchful dose, but now we're seeing that even at 50 morphine equivalency per day, there is still significant risk. And we have a huge population of patients that are on 50 morphine equivalency. So again, we can see that the signals continue to show a positive response even at these lower doses. Another complication of opioids is addiction, so chronic pain and addiction. So for patients receiving prescription opioids for chronic pain, do they develop addiction or they do not develop addiction? And that again, in fact, is a myth. And in fact, recent research has shown that about 5 to 10% of patients prescribed opioids for chronic pain actually develop a misuse disorder, whereas the risk of misuse or abuse or aberrant behavior can range up to 26%, so much higher than we once believed. This study done by Chu and colleagues in 2014 looked at a whole bunch of different uncontrolled studies to a sense of the estimates of opioid abuse, addiction, and they found a lot of variability. But what they did show is that those that were using opioids for chronic pain, the diagnosis of opioid abuse was between about 1 to 8%. The rate of dependence was 3 to 20%, 26% in primary care settings. The rate of misuse was 8 to 16%, and development of addiction was 2 to 14%, and the rate of aberrant behavior. So this is behavior such as positive urine drug screen, double doctoring, maybe tampering with the dose, is up to almost 40%. So though there's a lot of variability, I think the take-home message from this study shows that the risk of ongoing high-dose opioids certainly is there when it relates to the development of addiction and misuse. Another study done by Edlin and colleagues in 2014 also looked at the link between chronic pain and addiction, and this is a population of newly diagnosed with chronic non-cancer pain. This is U.S. data over the span of 5 years, but this was a large population that they studied, so over 500,000 patients. They excluded those with prior opioid use or opioid use disorders, and anyone with cancer pain as well as those residing in nursing homes. What they wanted to look at is the association between opioid days supply, so either no use, acute use, so less than 3 months, and chronic use, more than 3 months. And then whether or not there's association with the duration of use, average daily dose, so none, low dose, medium dose, high dose, and the development of a new opioid use disorder. What they found was very interesting. So you can see in the chart here that as we move from a acute to chronic setting of opioid use, the odds ratio of developing addiction shoots up quite dramatically. And also there's definitely a dose response where by you move from a low dose, medium to high dose, again, that odds ratio increases. So for proceeding from acute to chronic opioid therapy, the evidence of efficacy decreases, yet the risk of misuse increases substantially. And it suggests that the risk of developing opioid use disorder is relatively small for acute trials of opioids. It's really when we make it more chronic and the doses start to climb that the addition of those two factors really drive that risk of developing addiction. There are many other risk factors we know in terms of age, previous history, and history of mental health disorders that are also associated with the development of opioid use disorders. So now that I talked about the two main risks, or the two sequelae of opioids being mortality and a development of addiction, what about the efficacy? Are they effective in treating non-cancer pain? And we know now from the 2017 guidelines, and in fact newer data, that opioids actually have a similar effect on pain relief compared to NSAIDs, TCAs, and Nabilone, and as well as a similar improvement in physical function compared to NSAIDs, anticonvulsants, TCA, and Nabilone. And overall, we have found that opioids really have a very moderate effect on pain, so a 10 to 20% difference in the pain scale, which is really not considered very clinically significant. We look at least a 3-point reduction or a 30% reduction in pain intensity to have a really good, robust effect. Again, opioids have a very small effect on function, so less than 10% change. So overall, with this data, a lot of these smaller trials and newer data that has come out looking at long-term use, there's no good evidence that opioids really improve pain or function in a long-term setting. Other clinical risks that we need to also keep in mind is central sensitization. So the phenomenon of opioid-induced hyperalgesia is a really challenging one to manage. And I think it's really counterintuitive when we speak to our patients about this, how, the use of a medication to treat pain, why would it worsen that pain? And we know that this is a very real phenomenon, particularly in those on chronic pain medication, in that it changes that pain pathway and really sensitizes a lot of the pain pathways and neurotransmitters, increasing their risk, increasing their experience of the pain. Opioid withdrawal-mediated pain, other medical complications which I'll talk about, and then again we spoke quite a lot about the risk of developing misuse and dose and overdose. So here I detailed some of the medical complications, and I think this is an area where a lot of patients don't have a lot of education around. I think many patients know what common side effects we often see with opioids, like constipation or drowsiness or dry mouth, but it's really the medical complications that are quite significant for patients and really important as pharmacists that we highlight to them when they make that choice to continue or to think about tapering. So certainly we see a definite risk in terms of reduction in sex hormones. So for women that might present as an irregular or loss of menstrual cycle. For men there's risk in terms of erectile dysfunction, impotence, and decreased muscle mass. And for both genders there's loss of sex drive or libido and risk of infertility. Central sleep apnea and or disordered sleep is a very significant side effect and probably leads to a lot of that risk of overdose, in that it does decrease that drive to breathe in the breathing center, and also disordered sleep. So opioids can inhibit that REM sleep, so that rapid eye movement sleep where there's more restorative sleep needed. And so if it fragments that area, patients don't have that good restorative sleep and maintenance. Medication overuse headache is a big issue, particularly in migraine populations. And I think that's a similar presentation as a hyperalgesia picture. Immune dysfunction is also seen in long-term opioid users, so those often present with more infections, osteoporosis, and fractures. And I suspect a lot of this has to do with the effects on testosterone and the balance of that hormone in terms of bone health. And then again, a complication as being addiction is a very real complication. So the next few slides will talk about the 2017 Canadian opioid guidelines. So these were put out quite recently, and they really have streamlined it compared to the 2010 guidelines that were published. So they streamlined it to provide 10 key recommendations, highlighting both from initiation of opioids, maintenance, and tapering. And they also delineated each of these recommendations through being strong recommendations. So if it's a strong recommendation, it means that almost all informed patients would choose that recommended course of action, and the recommendation is generally appropriate for most individuals. Some recommendations were weak, so that indicated that a majority of patients would choose that course of action, but many would not as well. So in those cases, clinicians should recognize the different choices and different options and be able to discuss that with patients as they move along that care pathway. So let's look at what these recommendations are. So the next two slides I'll delineate the 10 recommendations. So you can see here recommendation number 1 talks about commencing therapy. So they strongly recommend optimization of non-opioid pharmacotherapy as well as non-pharms rather than going right to a trial of opioids. So that's not a surprise to all of us when you think about almost like the WHO step ladder in terms of initiation of therapy. The second recommendation is those patients without current or past substance misuse disorder or without any active psychiatric disorder who continue to have persistent pain despite optimal non-opioid therapy. They do suggest a trial of opioids, but again, this is a weak recommendation. Recommendation 3 is a strong against, so anyone with an active substance use disorder, they strongly recommend against the initiation of opioids. Recommendation number 8, 9, and 10 now focus really on rotation and tapering of opioids. So recommendation number 8 looks at those who are currently using opioids who have persistent problematic pain or problematic adverse effects. They suggest a rotation to another opioid rather than keeping the opioid the same. And unfortunately, this is a weak recommendation, and we know this in practice that oftentimes how we rotate, what medication rotate, and what dose is really guided by clinical experience and a lot of anecdotal evidence. There's currently not a lot of strong randomized control trials that can really guide clinicians on how we can rotate patients. Same thing goes with regard to the dose. So for patients who are currently using 90 morphine equivalency or more, they suggest tapering opioids to the lowest effective dose and potentially discontinuing these opioids rather than making no change. So again, that weak recommendation has to do with how we taper, how fast, what regimen. Again, not strongly guided by robust data, but really a lot of anecdotal and clinical experience in how we do this. I'm hopeful in the next few years that more evidence will come out, more robust evidence will come out to guide us on how we can best and effectively taper our patients. And the last recommendation as it relates to tapering and the management of opioids is for those who have challenges in tapering, they recommend a formal multidisciplinary program. And this is a strong recommendation, and there's lots of data supporting disciplinary care to help patients with chronic pain. I think the big caveat being is we can recognize, and certainly in smaller centers outside, let's say, of Toronto or Hamilton or Ottawa, there are often resource issues in terms of getting into these multidisciplinary programs, and even in big centers, there's long wait lists. So often this may not be a very realistic approach for all patients who have challenges in tapering. So one of the qualifying statements they put in the guidelines is the use of other models of care, right? Other use of shared care models whereby you bring together the physician and maybe the nurse or physician and physiotherapist. And they also highlight the physician and the pharmacist being another model of practice where we can work with patients. It doesn't have to be a formal program, but these two clinicians can work together to help taper. So I think it was really, really hopeful that the guidelines highlighted the role of the pharmacist and really puts a challenge on us as clinicians to help with some of these challenging situations. So now that we think about tapering and making adjustments, who do we look at to make these opioid adjustments? So first of all, let's just pause and think about where opioids indicated. So there's a small group of patients, so certainly those with well-defined pain conditions, nociceptic or neuropathic, those with active cancer, and those at end-of-life palliative care. Those are conditions that maybe, opioids could be a good option. Obviously, we can look at side effects and function, but generally in that population. But there's also a big population where opioids are really not appropriate. So there are some relative contraindications as indicated in both sets of guidelines. So those with low back pain, headache, and fibromyalgia, which is challenging because those are probably the biggest diagnoses we see in our chronic pain settings, in our chronic pain clinics. And that's because there's just not a lot of evidence supporting the use of opioids in these particular populations, and certainly in the fibromyalgia population, we know that the use of opioids can actually further exacerbate the opioid-induced hyperalgesia. Any patients that are not responsible, social instability, those with acute psychiatric instability, high suicide risk, and past substance abuse, and those who are pregnant, those are all relative contraindications. Absolute contraindications are certainly, like the guideline said, anyone has active substance misuse, you certainly don't want to continue that patient on opioid therapy. This is obviously aside, not related to methadone or buprenorphine, which is a different use of opioids, but certainly we want to try to taper patients off or get them off of the opioid that they're misusing. Anyone with absolute absence of pathology, so we don't know what we're treating, that's a good opportunity to think about reevaluating. And then anyone engaging in any illegal activity, so any very concerning aberrant behavior would be means or grounds to taper. So this list helps to guide you. You know, when you think about how can we enhance the care of patients, how can I think about working with my physicians to provide that care? Maybe start to look at the relative contraindications. Look through your roster of patients. Who are your patients that have maybe some of these characteristics that you can target as patients that you can work together with the physician to think about a taper? So why don't we introduce Mr. JR. He's a 47-year-old male with spinal stenosis with chronic neck and back pain. And fortunately, he's contemplating a taper. He has a past medical history significant for COPD, depression, and sleep apnea. Current opioids, which he has been on for 5 years with a gradual dose escalation, is hydromorphcontin at 18 twice a day. So that gives you a morphine equivalency of 180. Some short-acting hydromorphone at 8 milligrams. He takes about 1 to 2 tablets, TID, a total of 6. So why don't we introduce Mr. JR. He's a 47-year-old male with spinal stenosis with chronic neck and back pain. And fortunately, he's contemplating a taper. He has a past medical history significant for COPD, depression, and sleep apnea. Current opioids, which he has been on for 5 years with a gradual dose escalation, is hydromorphcontin at 18 twice a day. So that gives you a morphine equivalency of 180. Some short-acting hydromorphone at 8 milligrams. He takes about 1 to 2 tablets, TID, a total of 6 tablets, which gives you a morphine equivalency of 240 in itself. So you add them together, so it's grand totals of 420 morphine equivalency. Very large doses, but not unusual to what we see in clinic. Now you think about, is it time to decrease the dose? So certainly he's already contemplating a taper, but we want to build a case, an indication for taper. So looking at risk, does it outweigh his benefits? Does he have lots of side effects and medical complications? Are they no longer effective, right? So how do we assess efficacy? Are the opioids being used to regulate his mood? So we talked about how he has a history of depression. Is he using it mainly to treat depression? And lastly, but very importantly, is there a presence of aberrant behavior? Okay, so thinking about some of these criteria will help guide you in terms of building that case of taper. This slide reiterates what we talked about from Mr. JR. Indications when to adjust opioid therapy. So the big one, no benefit. So no improvement in pain or function, at least 30% reduction we talked about. The patient requests a taper, or that pain condition resolves. We also want to taper when patient has abuse risk. So there's concerning aberrant drug-related behavior, or there is an overdose event that the patient has experienced. And lastly, if there's lots of medical complications or many kind of adverse effects that really make it uncomfortable for the patient to continue, and as well as those with maybe unstable mental health. All these factors, either by themselves or cumulatively, are very good indications to think about tapering. Why do we even taper? So available evidence, and from our clinical experiences collectively, suggests that patients who have persistent severe pain despite their opioid medications, oftentimes when they experience after a taper, same or improved subjective pain ratings. So that's really important to tell the patient in terms of what what other patients have experienced. That in fact, if you taper very gradually, so certainly outside of the realm of withdrawal, but once they stabilize on that tapered dose, many patients endorse that their pain has not worsened, but yet their dose has really reduced, and they start to feel improvement in function and mood. So again, those are two big benefits. Tapering helps because it helps to resolve that end of dose withdrawal symptom. This is a tricky phenomenon. Oftentimes patients, as they are on longer term opioids, near the time when they had to take the next dose, they notice a worsening of pain, right? Or they start noticing some withdrawal symptoms. That's very common in chronic use. So patients in that situation will feel that, okay, my pain is worsening, right? So therefore, if I take more opioids, it's going to help the pain, right? And certainly if you increase the dose for the short term, it does help the pain. But really what we're chasing is withdrawal symptoms. So it's not that the underlying pain condition has worsened. It's that because the patient is growing tolerant, they're having a lot of why do we even taper? So available evidence and from our clinical experiences collectively suggests that patients who have persistent severe pain despite their opioid medications, oftentimes when they experience after a taper, same or improved subjective pain ratings. So that's really important to tell the patient in terms of what what other patients have experienced. That in fact, if you taper very gradually, so certainly outside of the realm of withdrawal, but once they stabilize on that tapered dose, many patients endorse that their pain has not worsened, but yet their dose has really reduced, and they start to feel improvement in function and mood. So again, those are two big benefits. Tapering helps because it helps to resolve that end of dose withdrawal symptom. This is a tricky phenomenon. Oftentimes patients, as they are on longer term opioids, near the time when they had to take the next dose, they notice a worsening of pain, right? Or they start noticing some withdrawal symptoms. That's very common in chronic use. So patients in that situation will feel that, okay, my pain is worsening, right? So therefore, if I take more opioids, it's going to help the pain, right? And certainly if you increase the dose for the short term, it does help the pain. But really what we're chasing is withdrawal symptoms. So it's not that the underlying pain condition has worsened. It's that because the patient is growing tolerant, they're having a lot of withdrawal pain, the increase in dose is really just managing withdrawal as opposed to treating that baseline pain. As well as tapering helps to hopefully reverse some of the opioid-induced fatigue, sedation, and dysphoria. And patients overall endorse being more active and energetic. And this is really a great win. This allows that patient to engage in those non-pharmacological therapies that are so important in chronic pain management. And overall better pain perception, right? So hopefully lifting some of that hyperalgesia. Why do we even taper? So available evidence and from our clinical experiences collectively suggests that patients who have persistent severe pain despite their opioid medications, oftentimes when they experience after a taper, same or improved subjective pain ratings. So that's really important to tell the patient in terms of what what other patients have experienced. That in fact, if you taper very gradually, so certainly outside of the realm of withdrawal, but once they stabilize on that tapered dose, many patients endorse that their pain has not worsened, but yet their dose has really reduced, and they start to feel improvement in function and mood. So again, those are two big benefits. This slide reiterates what we've talked about from Mr. JR. Indications when to adjust opioid therapy. So the big one, no benefit. So no improvement in pain or function, at least 30% reduction we talked about. The patient requests a taper, or that pain condition resolves. We also want to taper when a patient has abuse risk, so there's concerning aberrant drug-related behavior, or there is an overdose event that the patient has experienced. And lastly, if there's lots of medical complications or many kind of adverse effects that really make it uncomfortable for the patient to continue, and as well as those with maybe unstable mental health, all these factors, either by themselves or cumulatively, are very good indications to think about tapering. Why do we even taper? So available evidence and from our clinical experiences collectively suggests that patients who have persistent severe pain despite their opioid medications, oftentimes when they experience after a taper, same or improved subjective pain ratings. So that's really important to tell the patient in terms of what what other patients have experienced, that in fact if you taper very gradually, so certainly outside of the realm of withdrawal, but once they stabilize on that tapered dose, many patients endorse that their pain has not worsened, but yet their dose has really reduced and they start to feel improvement in function and mood. So again, those are two big benefits. Tapering helps because it helps to resolve that end of dose withdrawal symptom. This is a tricky phenomenon. Oftentimes patients, as they are on longer term opioids, near the time when they had to take the next dose, they notice a worsening of pain, right? Or they start noticing some withdrawal symptoms. That's very common in chronic use. So patients in that situation will feel that, okay, my pain is worsening, right? So therefore, if I take more opioids, it's going to help the pain, right? And certainly if you increase the dose for the short term, it does help the pain. But really what we're chasing is withdrawal symptoms. So it's not that the underlying pain condition has worsened. It's that because the patient is growing tolerant, they're having a lot of withdrawal pain, the increase in dose is really just managing withdrawal as opposed to treating that baseline pain. As well as tapering helps to hopefully reverse some of the opioid-induced fatigue, sedation, and dysphoria, and patients overall endorse being more active and energetic. And this is really a great win because this allows that patient to engage in those non-pharmacological therapies that are so important in chronic pain management, and overall better pain perception, right? So hopefully lifting some of that hyperalgesia. How do we adjust? How do we taper? So the first and foremost thing I think we can all recognize that we have to be prepared, right? So you have to come up with a plan, in terms of how you want to approach the taper. You certainly want to work together with the patient to optimize all their non-opioid agents, as well support them. So if they have neuropathic pain, you want to optimize all those adjuvant therapies. And if patients are fortunate enough, you want to encourage them to, seek out those non-pharmacological strategies in their toolkit to prepare them as they taper. Very importantly, as it relates to chronic pain, we know that over 50% of patients have comorbid mood issues as well as sleep issues, so we need to address these conditions as well concurrently. If the patient is very depressed and you start a taper, certainly the outcome will not be advantageous, so you want to address those mood issues, make sure that it's stabilized and treated, as well as sleep issues. And then finally, once you have that all under your belt, then you can adjust that opioid. So you can either rotate, in which we'll talk about what rotation means. We can straight taper. And then part of that formulation is that proactive management of withdrawal symptoms and giving them education around what that looks like. Okay, so to adjust the opioid, the goal of the taper really, when we provide that education, is improved or no change in pain. Okay, so some patients that are very lucky actually get an improvement in pain, but the best or the worst case scenario is no change in pain. Okay, you definitely will see a decrease in opioid-related side effects and risk, increase in function. So again, discussing those meaningful patient goals with them. So they're noticing, I'm really cognitively dull with my opioids. You can use that as a springboard to discuss, well, if you taper, your mind will start to clear and you can start to maybe engage in more activities with your family or your grandkids. So really getting at the root of what is important to them. How we do that is helping them to set SMART goals. So we're not going to go into too much detail in this talk, and I have showed you what SMART goals stand for. So it's goals that are specific, they're measurable, they're agreed upon, realistic, and time-based. And this helps to really give it a very strategic way to set that goal for the patient. And it makes them more accountable to how they can go forth to achieve those personal goals. And this SMART goal is important because if you don't set it up strategically, oftentimes it's very hard to measure how far the patient has moved. A couple of things just to mention too, some clinical precautions. So some of these above clinical scenarios, it's not that we don't taper in these scenarios, but we would proceed with the taper with a little more caution, and in some situations we may need to call upon more specialized care, or call upon others that have a specialty around some of these more complex cases. So in the pregnant population, it's not so much we're worried about the mother, but it's more for the fetus or unborn child. We know that in a rapid or severe opioid withdrawal situation, it is associated with premature labor and spontaneous abortion. So for those populations, you may want to call upon obstetrics and gynae just to make sure they're involved as well if you're thinking of tapering. Anyone with unstable mental health or medical conditions, we know that opioid withdrawal can cause significant anxiety and insomnia. So that may exacerbate some unstable medical conditions. So certainly we want to just be mindful that any underlying medical issues that are not addressed, that we address them before we engage in a taper. Anyone that is addicted to opioids that are obtaining from multiple doctors, so getting off the street, borrowing from friends, double doctoring, really an outpatient tapering is probably very challenging and unlikely to succeed because it's really hard to control where they're getting opioids. So in those cases, those patients are best managed in a formal opioid agonist treatment program. So referring to an addiction specialist, someone who can help initiate methadone or Suboxone, is probably the best way to manage those type of patients. And then any concurrent medication. So always remember avoiding sedative, hypnotic drugs, especially benzodiazepines, during a taper, so not to complicate the picture and increase that risk of overdose.
So as we were talking about tapering of opioids, I think one really good reference I'm going to draw your attention to is a paper that myself and a few colleagues published a couple of years back in CPJ, so the Canadian Pharmacist Journal. And this is a really excellent guidance document giving you some clinical pearls, some frequently asked questions around the challenges of opioid tapering. So we talk about, questions that pharmacists commonly ask around how to approach a taper. Do we taper fast acting versus long acting? What is the evidence? What is the approaches? So I think this is a really nice guidance document to complement the opioid guidelines that we've talked about already as a quick and snappy tool to refer to when you're approaching a taper or you're running across some challenges with your patients.
So the first way we can approach an opioid reduction or a change in the tapering. We talked about what the benefits are, so that's shown in the dark blue box. And a couple of points to remember. So withdrawal from opioids is uncomfortable. So certainly it's not life-threatening. You can tell the patient, yes, it's probably the most uncomfortable thing they'll feel, probably like the worst flu they'll feel, but it's not life-threatening. Patients who are unable to complete a taper, it's always important to tell them that, it's okay to stay on that lower dose, right? As long as their mood and functioning has improved or hasn't worsened, it's okay to pause that taper and revisit it. And oftentimes patients are very scared, right? Once they start the taper, they feel all or nothing, that you're going to push them to completion, and that's not the case, right? Unless there's imminent risk in terms of overdose, in most cases we can go gradually at that patient's pace and pause and restart along the way. And again, that leads me to the point to say that taper rates can vary from patient to patient, depending on how long they've been on opioids, depending on the dose, depending on other comorbid risk factors. Generally, I put a very general range that the dose reduction can range from 5 to 10% of the total daily dose, and you can reduce it as fast as every 3 days, weekly, monthly, or every 2 months. And then once you reach that 1/3 of the original dose, smaller dose reductions are recommended. So maybe 5% every 2 to 4 weeks or every even 6 weeks, because as we reach those lower doses, that's when the patient has that higher risk of developing or experiencing withdrawal symptoms. So we want to go more gradual as we get to those lower doses. Couple of precautions. Once we begin the taper, really important to warn the patient not to resume that original dose after the taper has begun. And that's because that tolerance to opioids can be lost as quick as 3 to 7 days. So if they were to, let's say, go back to their dose, which was double what they were on, they're at an increased risk of overdose. So really important teaching point to tell the patient. Also to provide an opioid overdose education and dispense an naloxone kit. So again, it's hard during a taper, and sometimes if the patient goes back to the original dose, you want to make sure they have that harms reduction and the naloxone kit at home to keep handy in case something happens. This slide is more related probably for our physician colleagues, but same is true when we are working with our doctors, to never quickly or abruptly stop the opioids. For anyone, yourself or any patient that has been on opioids for at least even a week, they will develop dependence, physiological dependence. So quickly stopping an opioid will definitely put a patient through severe withdrawal, and that's very uncomfortable. And in some cases, patients may turn to illicit market for relief or obtain that opioid from other source. And we know that there's high risk with regards to overdose because we don't know what a lot of the illicit agents are laced with. There's high risk with regards to loss of tolerance, which we talked about. So again, really, really important when we're talking to patients, when we're talking to our physician colleagues, if we're starting a taper, not to stop it abruptly, that we really have to go gradually so that the patient doesn't suffer that withdrawal. So that's really basic in terms of the tapering and how we go about it. Again, it's more of an art than science, and we'll go over that case of JR a little later and how we can approach it. The bigger or the more challenging approach is the opioid rotation, and this is where oftentimes the physician will turn to you in terms of calculating the dose and how we go about doing that rotation. You remember from the guidelines that the evidence to support the practice of a rotation or switch is really largely anecdotal and based on a lot of observational uncontrolled studies, so not strong evidence. And the indication, as I mentioned before, is anyone who has bad side effects or current opioid, or they're just not having good efficacy. The rationale behind an opioid rotation is based on the wide individual variability in opioid sensitivity, and this is due to the phenomenon of incomplete cross-tolerance. So what that means is if a patient is taking morphine, they grow tolerant, the pain relief is not as effective as it once was. When you rotate, let's say, hydromorphone, though it's an opioid, the structure is different. So you almost, in essence, trick the body to provide better pain relief, hopefully, because they have not seen that agent. And also, big benefit is that you can significantly drop that dose of opioid because they're not tolerant to it or not as tolerant. This chart shows you how we can decrease that opioid dose. So if any patients on high-dose opioids, this was really actually delineated more in the older guidelines in 2010. In 2017, they didn't really break down high to moderate dose, but I put it here because in some situations we still do clinically break it down, just in terms of ease for patients. So anyone that's high dose, and I would say anyone above 100 morphine equivalency, and again, that's not based on strong evidence, but based on my clinical experience, anyone above 100 morphine equivalency, I'd feel comfortable dropping their new dose by 50%, and then converting it to that morphine equivalency. Patients that maybe are not as high dose, 30, 50 morphine equivalency, moderate doses, you can probably drop it by about 25 to 40%. So you give them 60 to 75% of their previous dose. Again, not hard and fast rules. Most patients I do drop 50% to make it easy. And I think the reason is I'd rather be a little more aggressive in my drop-in dose and have them maybe experience a little withdrawal. I can support them with some withdrawal management rather than dropping them too little and then risking that potential overdose, right? Because we're really kind of shooting in the dark in terms of the dose because of the variability between patients. So I'd rather be more aggressive and conservative in the new dose than risking overdose.
So when we talk about opioid rotation, so the previous slide I talked about the evidence and why we would consider tapering or rotating for that matter. And this is just a nice summary of how we would approach a opioid rotation. So these are some steps that I usually go through when I engage in patients in doing that. So the first thing is to sum the total daily dose of each opioid. So oftentimes you have patients that are on multiple different opioids. So you want to add up the total daily dose. So they're on fast-acting hydromorphone and long-acting. Get the whole dose of their hydromorphone that day, for example. Then once you have that dose, you want to convert it to the equal analgesic dose of the new opioid. So let's say you want to switch the hydromorphone to morphine, you would convert into morphine equivalency. And we'll go through an example in the next slide. Then once you convert it to the new opioid dose, you want to discount this opioid dose by approximately 25 to 50%. Again, this is to account for incomplete cross tolerance. And then if necessary, in some cases, you may need to allow some wiggle room to titrate up to effective dose. Okay, and what I mean by that is sometimes when I convert to a new opioid, I provide a long-acting dose, but you may also want to provide a short-acting dose as well, just for about 5 to 7 days, let's say, to allow that patient to titrate up, because you're really kind of guessing on that final dosage. Obviously, we want to be mindful that we don't escalate beyond the watchful dose or beyond 90 morphine equivalency. And then some clinical considerations. So certainly if you have patients that are more methadone or you're thinking about methadone, rotations around methadone therapy is quite complex. And because there's no real clear morphine equivalency, and methadone has a very narrow therapeutic safety window. So it's probably best managed by experienced practitioners, like people that are in addictions or people that have done a lot of rotations. So it's important to collaborate with some of those care providers. Buprenorphine rotations require special induction protocols, so it's beyond the scope of this talk, but certainly there's lots of resources that can guide you in considering some of these inductions.
So you can see here, this is an opioid rotation chart. I do want to give you a quick warning to be careful of where you find the charts. This is a chart that I took right from the opioid guidelines, so it's a vetted source. I'd be mindful and careful of those that you might find online through Google. If there's programs or pre-calculated Excel spreadsheets, I'm not sure how they calculate in the background, so best to go to a reputable source. So an example here is morphine ER 200 milligrams BID, giving you a morphine equivalency of 400 a day. You want to convert to oxycodone, so you look at the chart to convert from morphine to oxycodone, you multiply it by 0.667. Okay, so that's 266.8 milligrams per day of oxycodone. You recall it's a high opioid dose, so you want to reduce it by 50% to account for incomplete cross tolerance. So 266.8 divided by 2 gives you a grand total of 133.4 milligrams of oxycodone as your new opioid dose. You would then dose it based on what is available in the market. So I chose 60 milligrams CR twice a day. I have a statement here, if necessary, titrate the dose of extended release. And what I mean by that is sometimes I give or suggest giving the patient a short course of fast-acting opioid to titrate up to those optimal doses. Again, we're really stabbing in the dark. We reduce it by 50%. So in this case, I would give the patient or recommend the patient be given oxycodone IR 5 milligrams Q4H PRN, short course 5 to 10 days. Get them to track how much they're using per day so that when they go back to the physician and get prescribed that final dose. The physician knows clearly how much they needed through that titration period, and to give them that more representative dose for their pain management. But again, always remind the physician and the patient that the intention is not to continue on these fast-acting ongoing, but really using it in a short course for titration. Okay, so a couple of things to think about in terms of withdrawal symptoms. This is a very busy chart, and you can certainly review this. What I do want to highlight is that withdrawal symptoms will come about differently in different time periods depending on the pharmacokinetics of the medication, right? So those with short-acting opioids, you can see the onset of withdrawal can happen within 6 to 1 day, peaking between 36 to 72 hours. Long-acting opioids, any contents of ER, usually the withdrawal symptoms come about 12 hours to 2 days, so big ranges, peaking within 3 days. And then your super long-acting opioids, such as methadone or maybe even buprenorphine, onset of withdrawal happens between 1 to 2 days, again, peaking 3 days. These symptoms, there might be some overlap, but this gives you a general sense of some common symptoms that you'll see with each of these courses of opioids. And then the duration, again, depends on how the kinetics of the opioids in terms of how long that withdrawal lasts. But generally, most patients' withdrawal symptoms resolve between 5 to 10 days following a dose reduction, so that you can give that education to patients that as we taper, expect 5 to 10 days of feeling a bit uncomfortable, and generally your withdrawal symptoms will mitigate. Now, physiological withdrawal symptoms such as dysphoria or insomnia sometimes can take longer, particularly in patients with methadone. I've had a lot of patients that report that even coming off of methadone, they still feel kind of off, right? So sometimes it takes longer to resolve some of those physiological or psychological symptoms.
So I provided a chart for everybody to refer to help patients manage potential opioid withdrawal symptoms. I have on the left the target symptoms. So these are the most common symptoms one may experience when they're tapering. And then on the right, some medication and dosing guidelines. So let's go through each of the key symptoms. So nausea vomiting probably is a potentially common one. And what we recommend is either use of gravel or ginger as an example to manage some of these symptoms. We're seeing in practice some patients are being prescribed off-label nabilone, so that's the cannabinoid synthetic THC, to manage short-term nausea vomiting. You see prochlorperazine as well as Haldol. This is not ordered by preference. These are just a list of potential agents you can consider. Diarrhea, we can use loperamide or Imodium, and you would dose like you would normally do in the management of diarrhea. Myalgia, so your aches and pains are common in opioid withdrawal or tapering, so the use of basic analgesics such as acetaminophen or any NSAIDs, as long as it's safe for that patient population, are considerations for over-the-counter management. Then we have dysphoria, lacrimation, rhinorrhea, or itchiness. So some very non-specific symptoms. So commonly we may have that patient prescribed hydroxyzine for itch to manage that symptom. Insomnia anxiety is also a big one, particularly for patients that have a baseline issue with insomnia or anxiety. We can use short-term trazodone or amitriptyline at low doses. You can see the dose of 10 milligrams for insomnia. Pregabalin or gabapentin or nabilone is also commonly used for short-term to manage anxiety. We try our best to implement sleep hygiene measures as much as we can to manage insomnia. We really try to avoid benzodiazepine. Unless patients have an underlying diagnosed anxiety disorder, we try not to introduce another agent that can cause challenges with regards to dependence and coming off of it. So that's why we're avoiding benzodiazepines. And lastly, autonomic symptoms. So these symptoms include sweating, diarrhea, vomiting, abdominal cramps, just feeling chills or anxiety. So a lot of overlap with the other symptoms, but autonomic symptoms can be managed by clonidine, and that's a prescription agent traditionally used to manage blood pressure, but we can use in the short term at very low doses to manage these symptoms. You can see here I gave you a very basic dose titration schedule and some monitoring parameters when we use clonidine. And we would also be very mindful to taper clonidine, because if you were to stop the use of clonidine immediately, they would get rebound hypertension. And this is in the context of long-term use. So certainly if a patient is on clonidine for 1 or 2 days, that's not significant. But if we're needing it for the longer duration in withdrawal, let's say a week's time, then you do want to consider tapering it off gradually.
So we talked about the nuts and bolts of tapering, nuts and bolts of rotating. How about some of the soft skill? How do we intervene and begin the discussion with patients? So I find one thing that's really effective is collaborating with the patient and their family. You want to get that buy-in from the patient and all their support network. So many times when I do my consults, I do encourage patients to bring their partners or bring their daughters or family, because I think when they hear from their family what the family has seen happening to their relative, that's very powerful, right? So if a daughter says to mom, you know what, you've been on these opiates for a long time, and mom, I've really noticed that you're really quite forgetful, or you're very drowsy, or your mood is just really low. That's really, really powerful for the mom to hear, right? That a loved one has noticed this of them. So I think that's really important, if you can, to bring in the family. Working within their stage of change, which we'll talk about, utilizing MI, motivational interviewing. That is a whole different presentation into itself, but I'll introduce some key principles around that. And then recognizing the biopsychosocial approach to care. So that's recognizing that pain is a biological phenomenon, as well as a psychological and emotional experience, and a social experience too. So understand the context to which the patient lives, the context to their home environment, their psychosocial environment is really important to take into account when you talk about a taper. So all our type of care at our clinic, we do take into account these 3 spheres when we manage our patients. Developing that therapeutic relationship. So, further talking about that buy-in, certainly trust, respect, support, not judgmental. I can't stress enough. A lot of our patients with chronic pain feel very stigmatized when being on opioids. They feel that they've been lumped in with the population of patients that are misusing. So really putting that out there, right? So just calling it out that you're not here to judge and assume that they're addicted, and you validate that it's stigmatizing, right? So that you come across as on their side and as supportive of what they're going through. One really good thing, from a pharmacist's perspective, there's no power imbalance. So we don't hold a prescription pad. If we don't taper, we're not going to cut them off, right? So I think that's really important, and that's a really big advantage when we deal with our patients working with a taper, because they feel safe. They don't feel like you're going to stop or not take care of them, right? Because you don't prescribe the opioids. You're there to help them manage that medication safely. Empathy towards their pain and suffering. So I don't need to teach you guys that. I'm sure that with any chronic disease, we recognize how much suffering the patient goes through. So being empathetic, assessing that readiness of change, managing expectation is huge, right? So we always want to tell patients, whatever you're recommending, whatever pathway, that the pain is not going to be zero, right? We're not here to cure your pain. We're here to bring the safety, increase the safety, and to help you manage the pain better. So if we can bring that pain reduction to 30% less or 20% less, that's a win, right? So again, managing those expectations. And with any behavioral change, it takes several encounters. So think about your patients that you're trying to do smoking cessation, right? A one-time encounter may not be successful. So bringing this thought of tapering up in several encounters is helpful to slowly plant that seed. Here are the stages of change, and probably familiar to a lot of people. So I'm just going to show you, some statements that would help you understand where the patient's at. So if they're pre-contemplative and they have no intention to change, you'll hear statements like, I won't taper, I can't taper. And in this case, in these stages, it doesn't mean you give up and say, okay, I can't do anything. There's still a big role for you to play. So this is where you start to provide information about benefits and risks, right? So you're being neutral. You can recognize, I understand, or recognize you're not ready to taper or you're not comfortable with it. But here's some information I can provide you about why I'm concerned, benefits and risks. Be available. Continue to use those motivational interviewing skills. Now the patient moves towards contemplation. They're ambivalent, right? So they might start saying things like, I see why it's safer to taper, but the pain is so bad, right? So again, you continue to support them. You address, so what are your concerns? How can I support you to move along that stage? So address those questions. Continue to raise awareness of the pros and cons. So you say your pains, you say that you want to increase the opioids or you don't want to taper, but yet you have a lot of constipation, right? So to create that decisional imbalance. And then MI again. And then finally, they're in the preparation stage. They'll take action. They say, I'm going to taper. And here's when you help to develop that taper plan with that patient collaboratively. Then when they're in the action phase, you want to implement that behavioral change. I'm going to do it. So you can continue to help them to work on the plan, withdrawal management, providing support, being there, promoting their self-efficacy and their confidence to do this. And then certainly the maintenance phase. So again, providing continuous support. This change process is very cyclical and dynamic, right? So patients don't often go through step 1 to 5 in that order, right? They might move 1 step like a dance. They move 1, 2 steps, and they might move backwards again. And that's okay, right? So you just want to be mindful that, this is a dynamic process, and it takes some time for patients to move along that stage. And they can linger in one stage for longer or move through really quickly. So to reiterate, I'm not going to go into too much detail, but this is reiterating what I said in the previous slide. So if they're pre-contemplative, or they straight out disagree with tapering, and that could be due to many things. So they might have had poor experience in the past about tapering, right? So they may have been cut off and had horrible experiences. They might have own psychological barriers to change. There's certain fears and beliefs around tapering, or they just don't know a lot, right? They don't know what to expect, so they don't want to taper. So here you want to listen, ask, inform, educate, and encourage. Continue that spirit principle of MI. So motivational interviewing is really a collaborative approach in terms of communication. It's understanding their values, it's respecting their autonomy, and it's based on based on the principle of OARS, what we call OARS. So OARS, so OARS, open-ended questions. So inviting that patient to tell their story. What are the concerns you have about tapering? What are the concerns you have about taking the opioids? A is affirmation. So these statements are genuine statements. So you recognize that patient's inner strength and you validate their feeling and experience. So it's not about praising and saying you're really awesome that you want to taper. It's saying statements like you've given that taper a lot of thought and you've made that difficult decision to begin, right? So validating and affirming them. R is for reflection, so proving that you're listening and understanding. So you form a hypothesis. So you tell me you're afraid that you want that we make changes to your opioids too quickly, you'll suffer withdrawal, right? So you make a statement, you summarize what they tell you, and this is their opportunity to correct you or to say, yeah, you're right. So this helps them realize that you're listening. And finally, again, S is summary. So checking in your understanding, making sure that you're both on the same page. And this is where you start to link that ambivalence that the patient may have, those but statements to change talk, to moving along that stage of change. When they're contemplative, the patient needs to think about it. So again, some patients need more time to consider the idea of tapering. They may need to talk to others, their family members, before making that decision. Here's when you want to set up that follow-up. So how long, you may say to the patient, how long do you want to think about this? When can I check in on you about this? When can we do this follow-up, right? So I'm really concerned about your health. Really important not to lose that follow-up. You want to continue to touch base with that patient. Again, raising questions, awareness, pros and cons, using MI skills. And then finally, with all that work you've done, they're in the action phase. So they agree to taper, they're comfortable with tapering. Here's where you set those SMART goals, right? That specific plan, how that taper looks or rotation looks, how we're going to manage your pain and other non-pharmacologicals, how we're going to manage your withdrawals. We want to choose a good time, just like smoking cessation. When do we stop smoking? So we choose a time to taper. Certainly we don't want to taper during a stressful time, so maybe not around the holidays. Maybe you want to pick a time in the weekend where there's not a lot of commitment for the patient. You want to consider all your alternatives and follow up during the taper to address any issues. Again, here to support and promote that self-efficacy and confidence. You want to mobilize your team. So if you're lucky enough, like myself, to work in an interdisciplinary team, you want to bring together the MDs, your nurses, your colleagues, any kind of clinician, a psychologist, social worker. And what I mean by mobilizing is making sure everyone's on the same page. So it's not that they are doing this taper discussion with the patient, and making sure they know that this is the plan you're going to move towards, and hoping that these clinicians can also support in some of the therapy around this taper. Now, in community practice, you may not be fully able to mobilize this huge team, but you can also empower that patient, empower the MD and the patient to do so in their, let's say, family health team as well. Your role is excellent position to give that education. So we talked a lot about the education around opioid risk and benefits. Again, no negotiating or power imbalance. Oftentimes we have more time with the patients, or we have more touch points. They come to you every so often to get their part fills, right? So those are opportunities when you can have that discussion. Okay, so let's go back to the case of Mr. JR. So in the dark box, we talked about checking any unstable medical or psychiatric conditions, making sure he's not obtaining opioids from the street, making sure we're not adding benzos. Before we taper again, he's ready to taper, we emphasize the SMART goals. If you have a contract with him, you may want to review that contract and accountability on both parties that, should he run out on his medications, you're not going to refill it. We really want to keep on that schedule because it becomes very tricky if he starts to deviate outside of agreed upon parameters. You want to optimize all his non-opioid options, non-pharms, and then making sure he has, he has all those psychosocial supports, his family, his friends, his network. Okay, so the first session in your taper, you develop that plan collaboratively. So you can see here I have 3 options. So again, that goes back to the art, right? There's not a right or wrong answer. One option is not better than the other. How you choose the option is driven by the patient. So this is how I usually present to the patient. I said, there are 1 or 2 or 3 options we can do, and you let them choose. So in this situation, you can either, 1, rotate all his hydromorphone to a long-acting morphine. I chose morphine as an example, but that you could rotate it to, Oxy Neo or fentanyl patch, depending on what they've tried in the past. You discount by 50%, and then you may continue to taper down the way. So again, this example here, 420 divide by 2, so it's 210. Morphine equivalency is a new dose. That equals to morphine SR 100 BID. Another option, you might say, okay, why don't we streamline all your hydromorphone content to one long formulation, and then we can clean that up and taper. So you remember he was on IR and content, add it all together, make it a hydromorph content, so the dose would be higher hydromorph content, but you've gotten rid of the fast acting. It makes it a much cleaner agent. It makes it much more stable from a pharmacokinetic profile. Then you can slowly chip away. Option 3, you may say to them, some patients are kind of resistant to streamline, so you may say to them, what do you want to taper first? Do you think the IR is easier or the content is easier? You let them choose. And these are what we call low-hanging fruit, right? So a patient thinks, sometimes they'll say to you, the IR, I don't really find much benefit. It's just more of a habit I take, and then start to taper that first, right? Whatever you can do to get those small wins to bring down that dose. Okay, so let's say you start tapering Q2 weeks, right? So at the week 2, you are following up and dispensing at frequent intervals, so maybe weekly, so making sure he is on track. You reduce the dose by 10% of the daily dose every 1 to 2 weeks, depending. Try not to give any PRNs. Once we reach those lower morphine equivalency, so I say about 60 morphine equivalency, you really want to slow that taper down, stretch it out a bit to make it more comfortable for the patient. In terms of monitoring, again, I mentioned before, you can hold the dose if the patient has severe withdrawal. Generally, most withdrawal mitigates within 10 days, but for some patients, it may last longer or may be very severe. So in those cases, you may want to just hold the taper, right? You want to schedule those frequent visits via phone or them coming into the pharmacy, monitor pain, function, mood, SMART goals. And then for some patients that maybe have more risky behavior to begin with, you may want to do random burn drug screens to make sure they're compliant and not misusing other agents. And then finally, months or weeks or whatever, you complete the taper, you want to celebrate, right? Because that's a big, big task that the patient's done. It's been, hard work from your part as well as the patient. So it's really important to also celebrate and validate how hard it was for the patient. The other slide, I think I talked about monitoring, but I just want to review in terms of timeline. So when you rotate, generally I monitor faster. So I monitor within 3 days. So you want to do more of a tolerance check. to assess, one, for oversedation, because you remember I said the new doses, you're really kind of shooting in the dark, so you want to make sure the patient's not oversedated. And you also want to monitor for pain relief. So checking in, how much fast acting are you using, right? How are you feeling so far with regards to that rotation? Okay. If you're tapering the patient, your frequency of monitoring depends on how fast you're tapering. So if you're doing Q weekly, you monitor in a week. If you tapering Q 3 weeks, you check in 3 weeks. And then again, for all those parameters, checking for goals, pain, sleep, physical activity, stress, mood, any withdrawal symptoms. And again, I talked about the urine drug screen. A couple other big concepts that I wanted to highlight as well is the concept of structured opioid prescribing as safe practice. So we talked a lot about patient education, risk, and treatment outcomes. We talked a lot about, or we mentioned the use of the naloxone kit for harm reduction. Another big one is safe storage and disposal of opioids. So, encouraging that patient as they're tapering or as they're getting rid of their opioids to return it back to you to dispose it safely. We don't want to, chuck it in the garbage can to increase that load in the community. If there's a written treatment agreement, or if there's not, you may want to start a treatment agreement to make sure that the patient, yourself, and the physician each know the accountabilities and making that care transparent. We want to shorten dispensing intervals, so limiting the quality and the load of opioids in the community. And then frequent monitoring. So it could be urine drug screens, it could be pill counts. Not all patients you have to do this. It depends on that patient profile. This structured open prescribing is really becoming a norm in terms of safe practice. So I usually describe this to patients that I'm not singling you out, asking you to do urine drug screen or write agreements, but it's as a standard of practice in terms of harms reduction. And usually the patients are quite agreeable to engage in some of this. Okay, so the next few slides before we end our module will be about collaborating with our care providers. And that's key too. So we talked a lot about collaborating with our patient, how we engage them. But another one is engaging our physicians, right? To engage them in how do we do that taper. Some key challenges that are very common that we hear about is miscommunication and making recommendations. So anytime we collaborate, we want to try to do it verbally if we can, or written in a formal consult when providing patient-centered care. Faxing is okay for product-centered, but really if you want to drive patient clinical care, you want to communicate verbally or written. You may want to decide when you need direct communication, so when it's more urgent, or when you can delegate it to your support team. And always be very respectful of the MD's professional judgment, right? I think, especially in the realm of opioids, there's a lot of disagreement between clinicians in terms of what is right and wrong, but at the end of the day, you have to work closely with your physician colleagues, so being respectful of their expertise, and more importantly, respectful of the relationship they have with the patient. You know the patient a certain way, and the physician may know the patient more, right? So you don't want to make assumptions about what is happening between the physician and the patient, so being very mindful of that. Okay, so those are some key tensions. Another one is role ambiguity and mismatched expectations. We are, as we can attest, medication experts. We have, years of training as pharmacists, so I think it's important to own that, right? To own that you are, and take that accountability that you are the expert in the medication realm. We are collaborators, and important when I communicate with my docs or any clinician that you include your credentials, right? So that's very important to show the training that you have. You may want to list your patient-centered services. So in terms of selling some of the services that you can provide to your colleagues, list them in a newsletter. Let's say if you work in a family health team or a clinic, those are important things for clinicians to understand what that pharmacist does, right? And then going back to my discussion about how do we decide what patients to share care with our physicians. So making that list of complex patients. So those patients that have relative contraindications or absolute contraindications to opioids, we can start there, and you can then broach that topic to the physicians. Hey, Dr. Smith, I noticed that, Jane Doe is, a patient that would benefit from taper, right? So you approach that physician and offer to provide that collaborative care. And I don't think anyone would reject that offer. And then you can utilize your students. The other slide, I think I talked about monitoring, but I just to review in terms of timeline. So when you rotate, generally I monitor faster. So I monitor within 3 days. So you want to do more of a tolerance check to assess, one, for oversedation, because you remember I said the new doses, you're really kind of shooting in the dark. So you want to make sure the patient's not oversedated. And you also want to monitor for pain relief. So checking in how much fast acting are you using, right? How are you feeling so far with regards to that rotation? Okay, if you're tapering the patient, your frequency of monitoring depends on how fast you're tapering. So if you're doing Q weekly, you monitor in a week. If you tapering Q 3 weeks, you check in 3 weeks. And then again, for all those parameters, checking for goals, pain, sleep, physical activity, stress, mood, any withdrawal symptoms, and again, I talked about the urine drug screen. A couple other big concepts that I wanted to highlight as well is the concept of structured opioid prescribing as safe practice. So we talked a lot about patient education, risk, and treatment outcomes. We talked a lot about, or we mentioned the use of the naloxone kit for harms reduction. Another big one is safe storage and disposal of opioids. So, encouraging that patient as they're tapering or as they're getting rid of their opioids to return it back to you to dispose it safely. We don't want to, chuck it in the garbage can to increase that load in the community. If there's a written treatment agreement, or if there's not, you may want to start a treatment agreement to make sure that the patient, yourself, and the physician each know the accountabilities and making that care transparent. We want to shorten dispensing intervals, so limiting the quality and the load of opioids in the community. And then frequent monitoring. So it could be urine drug screens, could be pill counts. Not all patients you have to do this. It depends on that patient profile. This structured opioid prescribing is really becoming a norm in terms of safe practice. So I usually describe this to patients that I'm not singling you out, asking you to do urine drug screen or write agreements, but it's as a standard of practice in terms of harms reduction. And usually the patients are quite agreeable to engage in some of this. Okay, so the next few slides before we end our module will be about collaborating with our care providers. And that's key too. So we talked a lot about collaborating with our patient, how we engage them. But another one is engaging our physicians, right? To engage them in how do we do that taper. Some key challenges that are very common that we hear about is miscommunication and making recommendations. So anytime we collaborate, we want to try to do it verbally if we can, or written in a formal consult when providing patient-centered care. Faxing is okay for product-centered, but really if you want to drive patient clinical care, you want to communicate verbally or written. You may want to decide when you need direct communication, so when it's more urgent, or when you can delegate to your support team. And always be very respectful of the MD's professional judgment, right? I think, especially in the realm of opioids, there's a lot of disagreement between clinicians in terms of what is right and wrong. But at the end of the day, you have to work closely with your physician colleagues. So being respectful of their expertise and, more importantly, respectful of the relationship they have with the patient. You know the patient a certain way, and the physician may know the patient more, right? So you don't want to make assumptions about what is happening between the physician and the patient, so being very mindful of that. Okay, so those are some key tensions. Another one is role ambiguity and mismatched expectations. We are, as we can attest, medication experts. We have years of training as pharmacists, so I think it's important to own that, right? To own that you are, and take that accountability that you are the expert in the medication realm. We are collaborators, and important when I communicate with my docs or any clinician that you include your credentials, right? So that's very important to show the training that you have. You may want to list your patient-centered services. So in terms of selling some of the services that you can provide to your colleagues, list them in a newsletter. Let's say, I don't know if you work in a family health team or a clinic. Those are important things for clinicians to understand what that pharmacist does, right? And then going back to my discussion about how do we decide what patients to share care with our physicians. So making that list of complex patients. So those patients that have relative contraindications or absolute contraindications to opioids, we can start there, and you can then broach that topic to the physicians. Hey, Dr. Smith, I noticed that, Jane Doe is, a patient that would benefit from taper, right? So you approach that physician and offer to provide that collaborative care. And I don't think anyone would reject that offer. And then you can utilize your students, right? So we have lots of pharmacy students. Encourage them to do brief critical appraisals or maybe review new guidelines or evidence. And those are good, quick, snappy information provide to the physicians, right? Those are very helpful for them in terms of drug information and critical appraisal. So again, going back to understanding what our roles are and to kind of sell our services and what we are good at in terms of our value add within that care circle. So when we communicate with any clinician, we want to be concise and clear and confident. One approach is a brief note could include one to three sentences describing the scenario, the assessment, recommendation, plan. So an acronym is SAR, but there's tons of different types of ways you can document, like SOAP documentation, DRP. But I think the key components is give the background, what you assessed, and your plan. You conclude by welcoming collaboration, and then you provide, again, your contact information and your credentials, so who you are, and what you can provide. So this documentation I adapted from the Leslie Dan Faculty of Pharmacy. They have posted several modules several years ago on the OCP website on how to improve patient care from a pharmacist perspective, and this is a very good module that they talked about some of those key challenges of physicians. So a lot of the material that I've talked about in the previous slide was gleaned from these modules. So I really highly recommend you check some of these out. But so this is an example. So dear Dr. Grant, during a medication consult with Amir D'Souza, you have the date of birth, he disclosed that his medication, that he's been experiencing excess sedation that's limiting his ability to carry out his daily work with minimal improvement of pain, right? So that's a scenario. What did you do? I educated him on the role of his hydromorph continence playing in this, and that other agents may be preferred in managing his OA. He's open to trying other pharmacotherapy. Plan. I recommend tapering off his hydromorph IR while initiating duloxetine 30 milligrams daily times 7 days, and titrating up by 60 milligrams as tolerated. Okay, and then use a duloxetine. Please advise I can be contacted at X, and then you sign off your credentials and how he can contact you. So again, this is a very quick and snappy note. You can see it's several sentences, but it's very clear and concise, and it provides all the information the physician would need to make that clinical decision to either agree or disagree, and you provide that plan clearly for him. So with regards to documentation, all of us know that through the Ontario government, we can be remunerated in terms of doing meds check follow-up, so the website's there in terms of the forms that need to be filled out to bill for some of these services. Another step towards that is a pharmaceutical opinion. So I've included a link from OPA as a template that you can use if you want to do those pharmaceutical opinions, and an opportunity when we talk about tapering or rotation. This would go into one of these pharmaceutical opinions that you can bill for and show that value add in terms of your consults. So please look at that link to get a sense, and there's many different templates, but this is an excellent one to begin with. Documentation etiquette comes to no surprise. Three key things I've highlighted here. Professionalism, so spelling and grammar, always very important to reread your document to spell check and make sure the grammar is appropriate, because that speaks a lot to your credentials and professionalism when you speak to your colleagues. Please avoid accusations or negative tones. So, sometimes we may not agree with one another, but we still want to be tactful in our communication. Being diplomatic, so avoiding those judgmental words. This is wrong, you must change, unreasonable. So again, that puts that clinician on defense, right? So that's not helpful in developing that therapeutic relationship. Being clear is very important. And I struggle with this as well, because oftentimes I want to include all the details. So with that, I'm going to end the module. I hope you guys enjoyed the discussion today, and thank you for having me speak about a topic that I'm very passionate about.